All right, let's dive right into this explainer on the newly updated 5th edition of the ADA Infection Prevention and Control Guidelines. Look, as dental professionals, we all know the stakes are incredibly high, right? In this document, it's basically the absolute blueprint for keeping our clinical practices totally safe for every single person who walks through that door.
But before we get bogged down in the rules, we really need to pause and think about the invisible threats. We're talking microbes and aerosols that are literally floating in your dental operatory right now. So how secure is your clinic's invisible shield, really? Are your daily habits genuinely mitigating these risks, or are there microscopic gaps in your armor?
To build up that hierarchy of defense, we're going to follow a pretty clear roadmap today. We'll start with the duty of care, move into the hierarchy of risk control, touch on standard precautions, dig into hand hygiene and PPE, and wrap things up with managing bloodborne viruses.
All right, Section 1, the duty of care and the mandate for public safety. Let's establish exactly why these guidelines are so much more than just polite suggestions.
The Dental Board of Australia actually lays it out super clearly. The absolutely crucial takeaway here is that the responsibility for infection prevention and control rests squarely on your shoulders as the registered practitioner. It simply cannot be delegated to your support staff, your practice managers, or the practice owners. You personally own this obligation.
Moving right along to Section 2, the hierarchy of risk control, or how we actually go about systematizing safety.
Managing hazards is really all about a structured, layered approach. Honestly, your absolute best defense is just eliminating the risk entirely, like screening and deferring treatment for contagious patients long before you even reach for your gloves. If you can eliminate the risk, well then you step down to engineering controls, like high-volume evacuation, followed by administrative controls, and finally PPE as your ultimate last line of defense.
Okay, Section 3, standard precautions in practice. This is the universal baseline.
So standard precautions are your first-line everyday practices applied universally to literally all patients. By treating every single person with this baseline defense, you completely eliminate the dangerous guesswork of trying to figure out who might or might not be infectious. You protect yourself, and you prevent the spread of infections in the community. No guessing required.
Next up is Section 4, hand hygiene and PPE. This is all about defending at the fingertips. Now, you're probably familiar with the 5 moments for hand hygiene. These are the absolutely critical junctures where there's a real, tangible risk of pathogen transmission. It's really about actively breaking that chain of infection before and after every major touchpoint in the operatory. When it comes to routine care on visibly clean hands, alcohol-based hand rub is incredibly efficient. Hand washing? That's strictly for visibly soiled hands, or, after toilet breaks. But here is a massive myth buster for you. Washing with soap immediately before or after using hand rub is completely unnecessary. In fact, it can actually strip your skin's natural lipids and lead to occupational dermatitis. So definitely skip the double cleansing.
When you actually do need to use soap and water, keep in mind that it's not just the soap doing the heavy lifting. It's the mechanical removal effect. That physical friction under running water is what truly clears away proteinaceous material and those stubborn spores.
To make your hand hygiene truly effective, you've got to embrace the bare below the elbows concept. Rings, watches, long sleeves, they are basically luxury condos for microorganisms. The skin right under a ring gets heavily colonized with bacteria, which severely compromises the fit of your gloves and pretty much defeats all your hand hygiene efforts.
Now, high-quality nitrile gloves are amazing. They protect against a ton of chemical and biological hazards, but we have to beware of a false sense of security here. Wearing gloves never replaces the need for diligent hand hygiene. I mean, gloves can have microscopic manufacturing defects, or they can develop tiny tears right in the middle of a procedure. So always clean your hands right before you put them on and immediately after you take them off. All right, bringing us to Section 5, managing bloodborne viruses. This is where the stakes get the absolute highest.
It is vital to recognize that if your standard precautions are robust, they are fully adequate for all patients. Adding extra special conditions for a patient with a known virus isn't just unnecessary, it's actually a breach of anti-discrimination laws. Just treat everyone equally because, frankly, your baseline defense should already be impenetrable.
62%. That is a staggering number. It represents the upper bound risk of hepatitis B transmission from an infected patient to a non-immune healthcare worker from just a single contaminated penetrating injury. That's a massive risk, and it demands our full attention.
When you really look at the data objectively, you see exactly why hepatitis B is a far more infectious threat in your clinic than HIV. I mean, while the HIV transmission risk from a needle stick is relatively low at 0.3%, hepatitis B can shoot all the way up to 62% and hepatitis C up to 7%. This really highlights the absolute necessity of maintaining your immunity through vaccination and obviously practicing incredibly safe sharps handling. But what if you're the one exposed? Well, as a practitioner, you have a strict duty to know your own BBV status and test at least every 3 years if you're doing exposure-prone procedures. But here's the incredibly positive news. If you are infected with a blood-borne virus, it does not mean the end of your career. Not at all. Modern antiviral treatments can achieve viral suppression, which allows a totally safe and legal return to clinical work once you meet the criteria.
So as we wrap up this explainer, I really want you to reflect on one final thing. Is your personal diligence strong enough to maintain your practice's protective shield? Infection control isn't just a manual sitting on a shelf, right? It's a continuous, active commitment. Take the time to review the full 5th edition guidelines and seriously ask yourself if your daily protocols truly reflect your ultimate duty of care. Are there any microscopic gaps in your armor? Keep learning, keep adapting, and most importantly, keep your patients safe.